Hello, friends. I know everybody's joining on and signing on. So we'll give us just another minute or two. We're super stoked you chose to spend a couple of minutes with us on this Thursday afternoon or morning, depending on where you're joining from. So we'll give it about 30 seconds or so, let folks sign on, and then we will be underway. If you can hear us and see us and see the slides, go ahead and drop a note in the chat. Let us know just to make sure we've got all audio, visual, all that kind of stuff rolling, and give us a heads up if you can hear us. Awesome. We got a couple of folks joining in. If you haven't been on a webinar with Provider Trust before, you know that we love the Zoom chat. So as we're going through the presentation today, feel free to make a ton of use of it. Let us know if you got questions. Let us know if you got insights. We'll even ask some questions along the way and ask you to fill in some chat as well. So don't shy away from using the chat. We're big fans of it. We'll give it just another couple of seconds. We got a couple of friends on the phone. I see Rob has joined. Rob, hello. Sheila, hello. Okay, let's go ahead and get rolling. Good afternoon, friends. My name is Dave, and we've got an awesome co-presenter as well, and Tim. I'll introduce him in a second, but we're really excited for today's session. This is it's a niche one, but a really important one in healthcare, and so we're really excited to bring it to you today. A couple of housekeeping things before we get rolling. If you haven't been to a webinar with Provider Trust before, you know that they are good for CEUs. So shortly following the presentation today, we will make sure to reach out and get you your CEUs for joining this session, which is a 30-minute webinar today. Again, a couple of other things as well. You will get a copy of the recording of today's sessions and the slides. So if you want to dig in a little bit deeper, we do have some slides in here that are actionable worksheets, if you will, with next steps on them. So you'll get a copy of all of that, and somebody will reach out to you shortly, either this afternoon or first thing tomorrow, with all the materials and just an offer to help walk you through them if you need it as well. With that, let's go ahead and get rolling on today's topic: best practices for monitoring, referring, and ordering physicians. And surprise, we're going to throw in prescribing and attending too throughout the presentation today. Two presenters. So if you've been on a couple of webinars before, you've certainly seen both of us from time to time. My name is Dave. I'm the Director of Marketing at Provider Trust. And we have just an industry veteran and leader in Tim Ridgway. He leads our sales and healthcare practice. He's our practice leader for the entire provider segment for Provider Trust. So he works a ton with non-for-profit, for-profit health systems, post-acute, acute facilities, and he's a veteran of healthcare. And we were thrilled to add him to the Provider Trust family a couple of years ago, and we're certainly lucky for you. He's joining today, so we're thrilled to have him today with us as well. Again, if you don't know who Provider Trust is, we are made with love in Nashville, Tennessee. We're a compliance monitoring company. We bring you insights from America's healthcare capital. We believe deeply that a smarter healthcare makes a safer healthcare. Our purpose and vocation at Provider Trust is to create a safer healthcare for everyone. And what we do very tactically, which gives us the authority to be able to speak on topics that we do on a monthly basis, is from healthcare license verifications to OIG exclusions, to just total enterprise compliance and eligibility monitoring. We bring you one platform that can do it all. It's a bit about what we do, which means we interact with all different types of populations. If you've been following along to the last couple of webinars, you know that we have sort of made our way through, as part of a series, we've made our way through different types of populations. So the last 2 months, we've talked a lot about employees and that relationship. Today, we've got physician populations. Next month, we're talking about vendor populations as well. And so we're slowly making our way through any type of relationship that typically interacts with compliance and or HR in some way, shape, or form. So without further ado, let's get to the agenda today. We're going to cover 4 things. We're going to go pretty quickly through the first 3 because number 4 is really the most important stuff and why you all signed in to listen to us today. The first one, we're going to go through the regulatory environment. I'm going to keep it simple, but I'm also going to keep it really direct. what does the OIG say about this type of population and where can you find it? So that way, as you're building out your compliance practices, programs, policies, or procedures, you know exactly where to go for the primary source data. Number two, what's the pain and what are we hearing in the market? I will be the first one to tell you, and Tim will tell you in a second, that this is evolving and it's emerging as a pain point in healthcare as the intersection of data and technology and the speed of adoption is interacting with how do we make smart decisions at time of care. And so as those things are converging in the physician world, it's also converging and emerging in the compliance world. And we've got a ton to share on that. I know Tim's going to take us through quite a bit. We'll go through navigating eligibility and what specifically does that mean. For some of y'all, this will be a bit of a refresher. For many of y'all, it'll be brand new because we'll be looking at it through the physician lens. And then lastly, best practices for monitoring these populations. So without further ado, I will go ahead and get us kicked off. I'm going to take us through understanding the regulatory guidance. And again, just like I said, keep it very simple, very direct. Some of this might be a little one-on-one, but ultimately, what we wanted to do is make sure it was just, what do you need to know about these types of populations and where can you go find it? So we're going to start with, I'm not going to read all these bullet points because if you've been coming to webinars with us, you have seen most of this stuff before. But what is a program exclusion, right? If you know what an exclusion is, it protects federal healthcare programs and beneficiaries from untrustworthy providers. No federal healthcare program payment may be made for items or services. Applies to direct providers as well as indirect providers, hence the population conversation. Employees and physicians would be direct providers. Vendors and subcontractors and FDRs would be indirect providers. There are federal OIG and state Medicaid exclusions as well. We'll get into that in a second. And a special advisory bulletin on the effect of the exclusion actually delivers a ton of guidance into these populations specifically. The OIG Exclusion Authority, right? So again, maybe 101 for a couple of folks on the phone before we get more specific into the physician populations. But the OIG has the authority to exclude individuals and entities from any participation in any federal healthcare program per the Social Security Act. There's two types of exclusions: mandatory and permissive. And the effect of that is that no federal healthcare program payment will be made for any items or services furnished, ordered, or prescribed by an excluded individual and entity. There is some nuance with that. So I will go ahead and just say right now that there is some nuance as to how that operates in the physician world. As an example, right, just to jump ahead maybe just a little bit. As an example, there's specific guidance around an excluded provider referring a service to a non-excluded provider. And what does that look like from a compliance perspective? We'll get into a little bit that in a second. We're going to highlight one document today, and we're going to send this out to all attendees and registrants as well. So if you're joining the session today, this is something that you'll get from us after, which is the OIG's Special Advisory Bulletin on the effective exclusion from participation in federal healthcare programs, which was published in May 2013. So at a 40,000 foot level, this document is a really good foundational framework for understanding exclusions and enforcement and how that relates to the physician world. The reason why is because there is explicit guidelines that relates to physician populations, even going so far as to say, how does this relate in an ordering world, in a prescribing world, in a referring world, in a referring capacity. There's explicit guidelines. And so I would really encourage y'all as homework to go through and actually digest some of this. But specifically, about physicians, all three of these bullets are direct quotes from that document, right? So from that OIG special advisory, here are 3 bullet points that call out specific guidance for this population. So first one here is the ACA Also modified and expanded the OIG's permissive exclusion authorities and amended the civil monetary penalties liabilities by adding a new provision that subjects an excluded person to liability if the person orders or prescribes an item or a service while excluded and knows or should know that a claim for the item or service may be made to a federal healthcare program. To avoid liability, providers should ensure at the point of service, right, at the point of service, and that's something that we're going to talk about quite a bit today, that the ordering or prescribing physician is not excluded. This is a trend. I'm going to stop us right there for a second, because this is a trend that we are seeing all over healthcare right now, is how do we move compliance monitoring upstream to actually fulfill the intent behind the regulation, which is at point of service. And the last bullet point here is the effect of OIG exclusion is to preclude payment by federal healthcare programs for items or service furnished, ordered, or prescribed by the excluded party. So the two things I'll highlight on this before we'll get into, like, what are we hearing? What are myself, Tim, folks that we work with hearing from not-for-profit and for-profit enterprise health systems is orders or prescribes and at the point of service. And there's tons of detail that goes even deeper in the actual advisory bulletin itself. So would strongly recommend as a next step following this session that you give it a glance. So now that we're anchored to where's the guidance, where's the regulatory guidance today, we're going to talk about the pain of ORPA, physician monitoring and compliance. And I'll let Tim explain what ORPA means.
Dave, thank you very much. Thanks for getting us to this point. I think going through that education on the front end provides so much context into what are the requirements, and frankly, as we descend further down into what does this mean to each of you and the populations that you're responsible for. I hope the next couple of sections will help really organize a point of view on, what should we be doing versus what are we doing, and what resources are available to help us do that. So when we're talking about monitoring a large network, and the size of a network varies obviously by client, right? So some of our clients that we're talking to and supporting in this effort have very large networks that they rely on to bring patients into their system. Others are new to the network and are trying to build it out, or don't rely as much on the network to bring the patients to have care delivered within their four walls. So when we say ORPA, we mean ordering, referring, prescribing, and attending, because anybody that is walking into your system may interact with a patient in a care delivery scenario in any one of these phases, right? So in the market, we do often hear ordering and referring and or attending, but we want to make sure that we're inclusive of all practitioners that are, again, stepping foot or virtually being embedded inside of your system as they're referring care or participating in care in your system. So when we're out there talking to organizations, and we've got some very large integrated systems that are innovative in how they're approaching the monitor populations and managing their risk, we've seen really three unique functions stand up to say, I really care about what is happening in this process, right? And the first function that is so natural to assume, right, that has a point of view here is compliance, in which there is a policy that's been created around who can and who cannot be involved in any sort of care delivery within our system, and what type of processes do we have in place in order to ensure that we're determining eligibility before they get too far into the care delivery, and what is the impact of that? So in the event we don't have a process that's able to find and capture any compliance risk on the front end, how far down the care delivery does that get before we recognize that this had happened? And what does that do to any sort of civil or monetary fines and penalties? Essentially, what type of conversation will I have with my state and federal regulators? And generally, what's the risk, right? A big part of this network in the ordering, referring, prescribing, and attending is that it's really an unknown quantity, right, for some organizations. What I mean by that is that it's really large, it's really hard to determine who is an active participant who actually has been furnishing or providing services in a more recent period of time. And also the requisition or the order that comes in for the provider or practitioner that's never crossed your desk before. How do you handle that? And that's where patient scheduling can really come into play, right? And are asking questions about, help me do my job better. Because I want to schedule this patient. I want to schedule it when the order is received. Obviously, there's different ways that this is handled if you are a for-profit versus a nonprofit organization. And that is really the nuance of your own process. But essentially, based on the mission that you have and the model that's been built for your system, we want to make sure that your patient scheduling processes, our patient acceptance processes, are equipped to be able to schedule the patient as quickly as they receive that order to reduce any referral leakage that may exist. So a lot of questions that we hear today is, I want to build a process for my patient scheduling or acceptance role so that they are in a very intuitive fashion, always requesting a verification to be performed for any of the folks that are actually walking in, being referred by one of the practitioners in their network. And then another function that we often see at the table here is revenue cycle. Essentially, if we're providing care and we're delivering services, am I going to get reimbursed for this? Or do we have a situation in which we're not billing? And how does that information, at what point in time in the care delivery is that information found, and how is that used? And if it was found any earlier or any later, what would be the impact of the organization, either financially or inside of the care delivery itself? Does your process effectively reduce revenue leakage is another really big question that revenue cycle is obviously trying to answer when they're talking about the monitoring of this large kind of unknown network. So obviously we're still expanding this conversation. As Dave mentioned before, it is maturing and it's maturing rapidly. So I suspect the next time we talk about this, we might have another point of view to bring to the table.
Thanks so much, Tim. And we're going to go through, one of the things that I think has been, we saw it in the regulatory guidance, and then we hear it in the pain as well, is how can you make sure that at time of care or at time of order, when the order was received, that all the necessary actions next can happen, which is in this world of eligibility. So when we think about eligibility, we think about it through a number of different lenses. Certainly we have a bias towards compliance. And what does that look like at our organization and what we typically see in these workflows? And so thinking about eligibility workflows for the referring and ordering and prescribing attendings, we wanted to just anchor to two things and just give a basic 101 that can then inform what we're prescribing as best practices and what can come next, which is exclusions and licenses. Those are the two common things that we are hearing from the market. When an order comes in, before I can schedule this patient or before I can bill for this claim, is the referring or ordering provider excluded? Or does the referring and ordering provider have an active, valid, non-sanctioned, non-suspended license that is in good standing with the licensing board? Those are the two critical workflows that we see interacting and intersecting with these populations on an ongoing basis and at scale and at speed, happening multiple times a day, every single day. And so anchoring very quickly, right? For some folks on the phone, this is going to be a little bit of a refresher, but if this is news to you, exclusion monitoring sources, there are 44 of those sources that we would recommend get pulled into whatever workflow you're defining for referring and ordering physician monitoring. It's the OIG LEIE, the SAM.gov, 42 state Medicaid exclusion lists. Those are the 44, plus anything else as well, right? So Medicare opt-out preclusion list, OFAC, SSDMF, anything that could potentially be critical to know at time of care. One quick note, just again, bonus round for those folks on the phone that potentially did not get a chance to attend HCCA's Compliance Institute conference that was 2 weeks ago. If you did not get a chance to attend that, the OIG came out with some updates and news and said that they are embarking on a multi-year project to modernize the OIG LEIE, which is certainly big news in our world. I'd imagine if you touch exclusion monitoring in any way, it's also big news in your world too, as that starts to modernize and impacts workflows. And so we will host plenty of educational content and webinars moving forward about that, but just wanted to just pause and give you a quick nugget of information that we were able to learn just 2 weeks ago from the OIG directly. Again, from exclusions, the state of exclusion, here's the universe of exclusions that need to be pulled into any sort of ordering and referring workflow as it relates to eligibility, which is the OIG exclusions, SAM.gov, and state exclusions. All in all, that equates to about 218,000 total unique healthcare exclusions that need to be accounted for at time of order or care. And then just fun fact, right? 50% of all state exclusions never show up on the OIG LEIE at all. And 43% of all OIG exclusions are related to license revocation in some way, shape, or form, which is why we're going to go into licenses as well. Again, maybe just a bit of a review. We have 2 quick ones here, but the challenges of state exclusions are the gaps in data. And so even when exclusions are reported from the state level to the federal level, the critical information is often missing when that exclusion actually does get reported to the LEIE. As an example right here, 60% of providers in Texas do not make it to the OIG. And when you look at surrounding states, there's critical information that are missing from exclusions in surrounding state Medicaid lists as well. Last quick note on exclusions before Tim's going to talk about licenses a little bit, right? Again, maybe just a bit of a review, but many state lists, A, are not published on a routine basis. B, have extremely limited data. There's varied list types. Gosh, if you're in this world, you know how annoying it is when one's a PDF and one's in a spreadsheet. One has a CAPTCHA associated with it. And I know if you feel that pain, you feel that pain, and you know what that looks like on as part of your workflow. And many state lists appear to have late reporting to the OIG. So again, maybe a quick refresher on exclusions. When we think about eligibility, critical to understand as part of your workflow. And then Tim's going to take us through the landscape of healthcare licensure.
Great, thanks, Dave. I'll be quick here. When you think about eligibility, it's not just are they able to provide care and that to be reimbursed by federal or state dollars, it's also complying to state laws. So do we have a mechanism or a process in place to ensure that a license is active and in good standing at that point of care? And that's a very difficult thing to do, either for your own internal employee staff and your medical staff, those that are licensed. And it gets even harder to do when you're looking at your network, the limited data that exists for those individuals, and trying to determine who's actually active in my network and who is involved in some sort of care inside of my system or my organization. So Dave, if you want to move to the next slide here, there's obviously a lot of folks that kind of fit in the mold of license verification requirement. When I say license, I really mean anything that is primary source verifiable. That could be a certification, that could be a registration, and obviously could be a license and many other types. Lots of these disciplines, lots of primary sources that exist across the nation. Some are state, some are federal. A lot of variability, these primary sources, which really impacts your ability to perform a verification. If you're trying to do that on your own, you often notice that the data and the format required to actually perform that verification differ significantly across each of these sources. And again, there are thousands of them. Some of these license boards lump data together, so it gets hard to kind of bifurcate the information or distill it down. If you don't have the right data that you're looking for, things like a punctuation mishap or missing dashes or initials or a prefix or suffix that you have or that the primary source has and you don't, can be really disruptive in trying to actually perform that verification. Same process exists with latency as we see with exclusions, or there's just generally poor reporting in some of these boards. Some of the boards don't even have automation that allows a quick lookup. It's a person and an email. Obviously, we've got to deal with the provider and any delays in their renewal. We've got to deal with the license compacts and how that interacts with my employee base. And last and not least, what we're seeing a lot of nowadays is the development of CAPTCHA. So if you do have an automated process that's been in place and you're starting to see and feel that verifications are being unperformed, that's likely because of the inability to navigate security measures like CAPTCHA. So a few things to think about as you're talking about challenges here. Dave, if you want to move to the next slide. We plan on kind of rounding out the conversation with best practices on monitoring this network. And hopefully this is where we're going to spend some time helping you define how to best solve for this problem. There are really 4 questions that we want to pose to the group for y'all to go back and think about. And those really start with where's the risk among the practitioners that are entering my system. It is different when you've got somebody that has come into your system via an order for an image versus somebody that has come into your system that's getting some sort of therapy. The process is significantly different around the delivery of care, how things are billed and reimbursed. As well, the regulations actually have a nuanced point of view on those types of transactions. So it's really important to start looking at, okay, where is the risk in my large network, right? And how can I better understand that? From there, it's about looking internal. So now I've got a better idea and a handle of my network, and we can certainly help with that at Provider Trust. But who needs to be involved in my system, and what processes are used, or what systems are used to make decisions that my team is actively using when they're having to make an eligibility or an acceptance decision. We often see that there's an EMR or EHR system involved in initial ingest of order and a decision made to either schedule or not, or do some additional work. We also hear that this can be an extremely manual process when an excluded provider is found. And how to navigate that is very difficult if you don't understand what systems and what processes exist today and which ones can be optimized. The third step is to just define the standard operating procedures of the criteria that you're monitoring against. One example of that is define the population, the scope of the population. We actually have a slide in a second that we'll use to talk about that. One example of those definitions are, when is the last time we've seen this individual in our system? When's the last time that they've sent us an order? What do we want to monitor? Is it for exclusions? Is it for status of licensure? Is it a daily conversation? Is it something that we want to do on a quarterly basis? Those are examples of defining the standard procedures. And then what happens when you actually have an exclusion or a licensure status issue? Defining that process is going to help you come to a resolution pretty quick. And then the last piece of this is that once you've got a system, once you've got a process, understanding within your organization, and you've decided to optimize that, involve yourself in the digital transformation initiatives within your system. Figure out how you can integrate this and automate the work so that you can reduce as much manual intervention as you can. Obviously, we know manual intervention is labor intensive. That costs money and people dollars, and it also creates quite a bit of opportunity for risk.
Thanks, Tim. And so I want to go on Tim's third bullet. What he just walked you through was defining standard operating procedures. And as part of that, criteria, scope, and frequency are 3 key words that we would recommend that you address with each of those ORPA, ordering, referring, prescribing, attending populations. What's the criteria, the eligibility criteria by which you want to make sure and make workflow decisions? What's the scope of who's included in that population? And what's the frequency that you're ensuring eligibility? Is that once a year? Is it once a quarter? Is it every day? Is it at point of care? Which certainly is what we would advocate for, is instantly at point of care. I want to make one, just because there was a lot of buzz in the chat about the announcement from the OIG about the LEIE. As part of the OIG strategy of modernizing the LEIE, they are, this is years away by their own words, but over the next couple of years, what they want to do is make the LEIE accessible by API, which means for instant queries, how can you include exclusion monitoring instantly as part of your workflows? Now, well, that's amazing, right? Because that's the direction the entire industry is going, and it's absolutely where the OIG wants us all to go, both vendors like us and providers like you. The piece to that I think is really critical is that the exclusion, the instant exclusion, is a piece of the eligibility story, right? We covered licensure today as well. And so when we think about criteria, certainly exclusions is a part of that, but making sure you have the ability to screen instantly for beyond just exclusions, inclusive of, but also to fit your entire eligibility criteria is going to become paramount. That's absolutely where the market is going. And so Tim's going to talk about a little bit of what that means in our world.
Thanks, Dave. So the last thing that we'll want to mention here is that we've developed some capabilities at Provider Trust that really create a very efficient, intuitive process to help organizations get their hands around their network and define an opportunity to create some criteria, scope, and actually be able to deliver upon that. So one of the enhancements and the innovations that we've made that, again, some of the most innovative organizations in the country are using is this concept of instant to ongoing and the difference between those two. So as David mentioned, and we've talked about a number of times, is that there's a verification of eligibility, that is by way of exclusion monitoring or a license verification, that needs to be done instantly. That is at the point of care. Should I, and what decisions should I make right now? And so we've enabled an opportunity via API and with an application inside of our platform that allows us to perform that instant verification that you then can get information back and be able to make a decision at that point in time. Now, what we do know is that once you've made an instant decision or you've got that instant information, you're making a decision. And if that decision is to allow the care to be delivered inside of this order, that you'll likely need to then monitor this person in an ongoing capacity. And so what this capability can do is perform that instant verification and convert them into an ongoing monitoring individual, so that we have an opportunity to step in and help manage and monitor that individual for as long as it makes sense to monitor them. And that's where some configurations exist to help you ensure that you've got the right populations being monitored for the right periods of time. And there's a lot more inside of that story, but I think I'll leave it there. What I would hope to see and have an opportunity to do is have some conversations with you. So in the event you've got questions about this, in the event you want to talk more about what you've heard today, if it's by way of the updates from the OIG via HCCA Compliance Institute, or if it's just general information about the importance of monitoring this population, we'd love to talk to you. And so we're certainly willing and open to do that.
Thanks so much, Tim. The other thing is I wanted to leave you with a couple of things as we wrap up in the next 60 seconds or so, is a quick worksheet on monitoring matrix. This is something that we use a ton, and we also teach and coach and lead other provider organizations, forward-thinking provider organizations, to adopt this sort of mindset, which is for each of those ORPA populations, ordering, referring, attending, prescribing, actually filling out your eligibility matrix. And a part of that is to say, okay, who's included in this, right? So scope, who's included, what's the criteria by primary source, right? So scope, criteria, and then frequency, which is instant, ongoing, or a combination of both, depending on what the actual workflow is getting through. So this is that worksheet that is a really good next step. I would just really encourage you to take 10 minutes over a cup of coffee sometime the next week and fill it out as best you can with a pencil, right? And say, okay, ordering, I think we've got about this much. Here's our scope. Here's our criteria, and here's the ideal frequency that we would monitor against. That is the most critical next step with this population, and one that we absolutely advise. I know several of y'all just chatted in and said, are we sharing the slides? Yes, right? So you get this from us. You'll have this, and we will make sure that we follow up with you directly to make sure it gets into your hands. Last couple of things are, Tim mentioned this. This is an educational presentation. But as a next step, we do believe deeply in this because we believe instant to ongoing is the future of patient safety. And if we get this right, it will lead not only to improved efficiency metrics for your organization, but it will lead to patients being safer across healthcare. So this is a capability that we believe in. I know we, as a next step though, instead of just trying to be all salesy on you, we'd love to just learn, because this is the direction that the market is going. And I would underscore that with the latest announcement from the OIG. The OIG is starting to make their exclusion data set API accessible because they want providers to start doing this stuff in real time, per going all the way back to special advisory bulletin, which says at point of care, right? That is the position of the OIG. That's why they're making the moves that they're making for the LEIE. That's why companies like us are trying to leverage that mindset and that thinking and saying, what could eligibility look like in real time for physician populations at time of care? And so we'd love to have to follow up with you if it makes sense. The last couple things, Red, if you're new to Provider Trust, we have an extensive library with a ton of content that support all kinds of stuff like this. It's all free on providertrust.com. So if you haven't checked it out, go to providertrust.com, give it a read. There's tons of resources there that will be helpful. And with that, we will wrap up for today. Thanks so much for spending the time. We're really grateful. There's a lot of webinars happening in this all digital world. We are grateful you chose to spend the time with us. We will send you the recording, the slides, CEUs, and we'll make sure somebody from our team follows up directly, especially to make sure that monitoring matrix gets into your hands. Thanks so much, friends. Have a fantastic rest of your Thursday.